Hi, welcome to Mad Medicine with Miss P. And today we're going to talk about how to do those notes, those kind of specific incident notes like dressing changes or placing a Foley or even an IV, that sort of thing. I notice I say that a lot. I'm going to try really hard not to. So, I'm running late today, so I'm going to try to get through this real quick, like just a couple examples. For instance, if you are going to place a Foley, I try not to write a book, but I want to sort of set the scene. So I may say something like 16 French Foley catheter, indwelling Foley catheter placed per MD order. I always kind of like label that note, whether it's a dressing change or an incident or a pain note. I always, kind of label it so the reader knows what they're about to understand. So I'll say something like 16 French Foley indwelling catheter placed per MD order, period. Please use good grammar, punctuation, and spelling. It really matters. How you look on paper is how they're going to perceive you in court. So, my basis here is always going to be number one, patient care, taking good care of that person, making sure that they are safe and in good hands and getting the treatment they need. But the other half is, of course, always watching out for you and making sure that you don't end up in court or end up in jail because of a mistake or an error or something like that. So let's kind of think about how we're going to say this and how to cover all bases. And like I said, I'll hand it to somebody else and say, read this and tell me what you think. Am I missing anything if I have time? And I know a lot of times you don't, but just in general, if it's a big issue, I might do that. So I'll kind of title it with that, and then I'll say, after the procedure was explained to the patient, assuming they're awake, alert, and oriented, and the patient consented or verbalized understanding, it's always a good phrase to use, while assuring patient privacy, the patient was placed in lithotomy position and using sterile technique. The catheter was inserted with 275 milliliters of clear yellow urine returned, period. That is not all one sentence. Don't forget your periods. The catheter was secured to the left medial thigh, and the bag placed on the hook bed below the bladder, is patent and draining, correctly, period. The patient tolerated procedure well, and that's all there is to it. So I know that as we're at the bedside with the student, and I'll say, you have to chart, what you did. Any skill you have to chart that you completed that skill. And I'll kind of rattle off something real quickly. And they're like, oh, you talk too fast. Never heard that before. You talk too fast. What'd you say? And I'm like, you don't have to be so worried about what I said. Think about what you did. Remember, we went in there and we introduced ourselves and we told the patient what we were doing. We ensured that they were okay with it, that they weren't going to fight us, or that if they weren't with it mentally, that we got some friends to help out and kind of secure the patient, or talk to the patient and make sure that they were aware of this, what was happening. Or if it was a severely demented patient and we had to put in a Foley because their bladder was going to burst, we got help to safely get the procedure done without anybody getting hurt. And then, using sterile technique, we inserted this catheter, which we found to be the correct size. Not that the doctor will necessarily tell you what size, but you can kind of look at the patient or get an idea, or your most average size of catheter or lumen that you need, whether it's an IV or anything like that. Kind of looking at the patient, you should have an idea of how to choose that. And then that you used sterile technique, placing this catheter. What did you get? How did it go? How the patient tolerated it? It really is that simple. You just kind of think of those 5 steps of how we did it. So for instance, like with a dressing change, assuming you're changing the dressing, that means there's a dressing already there. So you may say mid-sacral dressing change per MD order. Again, I kind of label it, let the reader know what they're about to get into. The old dressing was removed with scant yellow drainage noted, period. The wound was cleaned with or cleansed with normal saline, and dabbed dry with gauze, or maybe you had a specific solution you needed to clean it with, or that sort of thing. Make sure you put that in there. You can't leave anything up for, you think you're going to remember if it came down to it. To be specific on exactly what you used. Then the wound bed was 3 centimeters in diameter, beefy red with pinkish surrounding tissue. The site was redressed with whatever you put in there. Let's say we did packing. I might say with 6 centimeters or 3 inches, or however long it is, whatever you want to use, wherever you live in the country. If America ever got a hold of the metric system. Half-inch iodoform gauzed, packed gently into the wound with gauze placed on top of that with a 4x4 Primapore, placed over that, and then the patient tolerated the procedure well. Or some of you really like to say that you signed and dated the dressing, which is a given. We should always be doing that, but I know some people don't. So if you want to add that in there, that's fine too. And then always end it with how the patient tolerated it. And if they were screaming and uncomfortable, you need to say so. So what the old dressing looked like tells you what you need to put back on there. Yes, you have orders, but if you take off this saturated gauze that is just leaking and oozing everywhere, and the dressing just kind of lifted up off the patient because the adhesive isn't even on there anymore because of the amount of drainage you had, you're not going to put that back on. You're going to go need an ABD, or maybe they're ready for a wound vac or something like that, right? So the doctor is assuming that you, or the NP, that you were in that patient's room consistently doing the dressing changes. Then you go back to them and say, this is what I've got, we need to change it. And they're not going to say, no, just do what I said. They're going to talk to you about it. You're the ones that's doing it. Or maybe they're there and you can say, hey, why don't you come look at this real quickly? We need to change some orders and put something else on there. So if my orders say one thing, but I know that patient's not going to be able to tolerate it, that wound isn't going to be able to tolerate that type of dressing, I'm going to put on what they need to have put on and then go contact the doctor and say, hey, this is what I had to do. What do you suggest, or what would you like to change? So that old dressing really tells you a lot about what's going on. What about if there's frank blood? When you see that there is, occult blood coming from the wound, that's not a bad thing, but if it's hemorrhaging, it may be. So what that old dressing looked like tells you what is going on with the wound and what the next dressing needs to be, or if there's no change at all. So you're going to clean it first so then you can look at it. And if there's any active drainage, you would add that in there. Or I might even say no active drainage noted. I'll back up and fix my previous note and fix that and say, the wound bed looks like this, the surrounding tissue looks like this, no active drainage noted. Or if there is significant drainage, I'm going to say so, that there's current, active bright red, drainage, or if it's yellow or copious or opaque or, whatever, pussy, careful on your spelling, whatever you would want to say to describe exactly what's coming from that wound, because that's letting you know how that wound is healing, not just size and shape, but what's coming out of it. Or if there's a foul odor, you need to say so. Whew, I remember what's his name at the foot of the bed when we unwrapped that one lady's leg. I thought he was going to hit the deck. I can't even describe it. Let's say if you put cottage cheese outside in a sealed container for a month or two and then pop that baby open and took a good whiff. It was bad. But he had a good game face. Was that Josh also? I don't know. I feel like we did everything together. So anyway, that's how you would want to describe that if it were a dressing change. So if there was any packing or how deep, if there was any depth to it, you would say so. Length times width times depth. You don't have to say, it was this long or this width. It's always LWD. It's always length times width times depth. That's kind of a given. If you want to add it in there, that's fine, but you're just kind of letting people know that you don't know that that's the norm, and that's okay too. So that's about how I would describe those notes and how you want to chart it. And you just chart it exactly how you're doing it. As soon as you guys finish, or a student finishes a dressing change, you're always like, now how do I write that? I'm like, you write it exactly how we did it, right? We went in there and, we got the orders. We knew exactly what we had. We had our supplies. Then we went in there, introduced our patient. We gelled in, foamed in, or washed our hands. We put the patient in position to where we can do this procedure. And then we removed the old dressing. We looked at the old dressing and what it looks like and wrote it down, or, kind of made a mental note about how much drainage it had. Or if there was no drainage at all, you can say so too. And then we cleaned it really well so we can look at that tissue. You don't want to coat it with some scab that's going to, come off after you wash it. So what that wound bed and surrounding tissue looks like, and the measurements, and then what you redressed it with and how the patient tolerated it. It's always about those 5 steps. Kind of the same with your average API also, right? APIE or SOAPI, assess, plan, intervene, evaluate. So it's about the same thing. Let's say a patient complained of pain. So those notes, you do the same thing, even though it's not maybe necessarily 5 steps, you do the same thing. So you went in there and asked if they needed anything or had any issues or had any complaints. So maybe they hit the call light and you went in to see what they needed. And they complained of pain. So you would say so. Patient complains of severe lower back pain. The site was assessed with no edema or redness noted, period. Patient states that they have chronic back pain with previous back surgeries or injections or maybe there was a previous fracture, anything that you've got either in the history of the chart that you know for a fact or that they have told you. So you're not looking for a wound or something sticking out of them. I mean, you don't think that necessarily it's a tumor. If it's low back pain and on one side significantly more than the other and maybe a little bit higher than their hip, I may worry about that being flank pain and kind of try to rule out if it's a kidney issue. But for the most part, when these patients complain of pain, as long as it's not chest pain, that's a completely different story. Or when they start complaining about a severe headache, we're going to talk about those in a minute, completely different assessments. This is more of a chronic pain that you know that they've had, a fibromyalgia, deep nerve pain, chronic back pain, arthritis, those types of things that you can't necessarily go away. You still assess the site. So once you look at it, you determine there's no redness or swelling, you're not necessarily worried about infection. It's not like they've got a big boil going on back there. Then you're going to say, is it sharp, dull, aching, burning? How long have you had it? What makes it better? What makes it worse? Do a complete assessment. You don't just toss them a Percocet and call it a day. You have to make sure that that is not something that could be misinterpreted as much more important. So if that's all they've got, then you have them describe it. I would say like point with one finger. They may not be able to point back there, but I would say kind of point with one finger, especially if it's chest pain or abdominal pain. They're always like, my stomach hurts. And then they're pointing to their, pancreas or their, colon or their pelvis. So, nobody knows where their stomach is. So I always say like, point with one finger exactly, where does it hurt? And be specific. A lot of those things like, knee pain, shoulder pain, those are kind of joints you don't have to worry about it. When they're like, my leg is killing me. Well, to me, ding, 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 I'm going to try to rule out a DVT. Does it hurt when you flex upwards? Or how about when you go forward? Or you're going to look at the side if there's anything red, streaking, any edema, anything like that. Try to rule that out before you decide. Now, I'm not saying go massage your leg or have them dorsiflex and you don't want to pop that clot off, but you still have to see, does it hurt when they perform these maneuvers? So if it's chest pain, same thing. I'm saying point with one finger. Is it crushing? Is it dull, aching, burning? Does it go to, one shoulder more than the other? Is it going up the neck? Can you feel it in your back or, in the your shoulder blade, anything like that? You can't just toss these people some Percocet. I see it all the time. God bless them when the students chart. Patient complained of chest pain, Percocet given. Well, that's the entire note. I just clutch my chest and go find the nurse and make sure that that patient is okay. If they're on telly, you're going to check the telly, kind of rule that out. I may even say something like, patient is in current sinus rhythm via tele number 8642. I may even say like the tele desk was notified and state, no changes in rhythm and, we'll notify if there's any issue because chest pain is a big deal. You might as well yell fire in a crowd. It's a big deal. Quit acting like it's, no big deal. And when a patient says like, it kind of hurts right here. I'm like, all right, well, did you just eat, a sausage smothered in bacon wrapped in, a pancake? Or is it actual chest pain, and we're going to rule out. So when you read those HMPs, you're going to find that that's what the doctor's doing. The doctor or the nurse practitioner is trying to rule out, is it radiating anywhere? What did they just eat? Does it hurt more when you take a deep breath or hurt less? Is there any change in position? Did Tums make it better? Did nitro make it better? That's what lets you know if that patient has a significant problem you need to treat, or if it's just something that you can, give some pain medication to. I always say try to offer a heating pad or an ice pack, change in position, distraction, all of that really works. So make sure that that's what your note says. Patient complains of pain, they describe it, you're going to assess them, this is what it looked like, they had no pain upon palpation or rebound tenderness, no change in pain after a change in position, they refused a heating pad or an ice pack or whatever you can, warm moist cloth, not like we have heating pads in these facilities, but something to that effect. And then they said, no, I just want my Percocet. And I will quote that. Patient states, no, I just want my Percocet, and use those quotes. Percocet, 5 milligrams given PO per MD order, PRN Q 4 to 6 hours, whatever the order says. I'll kind of add that in there. And then you will reassess them in 1 hour. But don't forget that you still want to try to get them to avoid those narcotics at all costs. Half these people have like severe abdominal pain because they're constipated. What do we give them for it? A freaking Percocet. So for the love of God. That is not helping anybody. See if you can't do something to make them feel better. Encourage ambulation or movement or abdominal massage or anything other than a narcotic, increase their water consumption, and try to distract them the best you can to avoid that. And some of these patients, that's what they want, and you're not going to get around it. Or their Lyrica or their Neurontin or whatever they take, do what you got to do, and then you may not have another option. Let's say you're starting an IV. I would do the same thing. I would say 20 gauge IV placed in the left hand without event, or times one attempt. It was secured with a Tegaderm or, a biocclusive dressing, and, the patient tolerated procedure well. And always make sure that the location and that size of the gauge is in there. If you got any other questions about any other specific notes, I know I'm kind of in a rush, and I'm sure I'm breaking your heart being under 20 minutes. But if you think of anything like that, those are kind of just the gimmies that you're going to see frequently. Just make sure anytime someone says anything like the headache, like we talked about. So we talked about the chest pain. When they say chest pain, you're like ding, ding, ding. Rule out any significant cardiac issues. So when someone complains of a headache, and I see this a lot, they're like, okay, I'll get you some Tylenol. No assessment. What's the first thing you want to do when someone complains of a headache? The number one thing you want to immediately do when somebody complains of a headache. Right, good. Check their blood pressure. Because if you think people don't die of hemorrhagic strokes or a cranial bleed from uncontrolled hypertension, you're wrong. Because it does happen. And young, otherwise healthy people can pass away and before your eyes. And there's nothing you can do about it except had you checked their blood pressure or forced them to get their blood pressure checked and then sent them to the ER immediately, just maybe they'd still be here. So when someone says, I have a headache, again, I'll ask them to point with one finger while I'm checking their blood pressure. I'll say, does the light bother you? Does it come and go? Is it pounding? Because remember, what is a pounding headache? That's a vascular headache. Right? Those are symptoms of migraine, right? If you have photophobia, nausea, a pounding headache, that's that cluster of vessels in the center of your brain called the circle of Willis that are pounding against the beat of your heart. So that is a vascular headache. So even if your blood pressure is not high, that's still some rebound dilation going on in the brain. And you can Tylenol them all you want, but what fixes it? Caffeine, right? A vasoconstrictor. So if the blood pressure can tolerate it and it's not a hypertensive headache from an intracranial bleed, then you can give them some caffeine and not worry about it. So always check their blood pressure first. And you know what? 9 times out of 10, maybe 90 out of 100, maybe 99 out of 100, it's probably nothing. It's just a headache. But I'm not going to be the one to not check those things first. So someone complains of chest pain, you jump the gun, rule out everything, act crazy, do anything you can to make sure it's not what you are worried that it is. And then you can go ahead and give them some Pepcid and call it a day. Same thing with the headache. Those are the two things. And the only thing worse than that is a sudden onset of shortness of breath and upper back pain. Yeah. Oh, well, here, let me give you a Percocet. For a PE, not going to help. Percocet's not going to help a PE. That's when you say, whoa, can you take a big deep breath? Does it hurt when you breathe in? And then you see, do we have an even rise and fall of the chest? And does a change of movement make it better or worse? And do they have that sudden onset of shortness of breath? All of those things, yeah, that's when you call 911. It's not when you go get a Percocet or some Tylenol or a Lyrica. Yeah, none of that's going to help that. So learn how to assess these things. And you know what I always do? I always jump the gun. I always think, oh my gosh, this is what's happening, and we need to, jump on it, and I'm going to rule everything out. And then afterwards, I'm like, oh, it's no big deal. Some Tylenol fixed it. Okay, great. What if Tylenol didn't fix it and there was a much bigger problem and we just missed it? Right? So yes, because I'm a nurse, when my daughter says that, my leg hurts, well, obviously it's lymphoma. Right? Clearly it's bone cancer. I mean, I'm a nurse. What else could it be? It's got to be that, right? So I jump ahead and I'm like, okay, well, when did it start? And how long have you had it? And is it cramping? Like, I know what bone cancer feels like, and I'm kind of going through all this. And I'm like, okay, if in an hour she doesn't say anything, it's probably nothing. But yeah, that's kind of where my brain goes. And when you become a nurse, it's going to happen to you too. You wait and see. You're just going to jump ahead and freak out and assume it's, much worse than it could be. Okay, so I'm just going to kind of keep this quick and short, for the 9 of you that are watching these stupid videos. I'm sure it'll pick up when we get into meds and that sort of thing, but right now we're just going to kind of keep it simple. And, my little pet peeve, I'm going to have one that actually requires an illustration, what I'm going to have to deal with later today, and I'm going to think this is exactly how I'm going to draw it out, because it's literally going to happen to me later today, and I'm going to eventually get to that one pet peeve, but I fear it might require me to raise my voice and maybe swear a little bit. So I'm trying not to do that pet peeve anytime soon. So real simple, because this happens almost every day. If I have something in my teeth or lipstick on my teeth or a gob of black stuff in the middle, tell me, come on. I mean, you know how irritating it is to be at work for 2.5 hours and then I go to the bathroom, take a quick look, and I've got like a gob of something, or I rub my eye and I have no eyeshadow on one eye and there's eyeshadow on the other. Or I rub my eyebrow off. Yeah, because those babies are painted on. I don't have much of an eyebrow, but I shellac the babies on. So I like rubbed it off or it's smudged. Like, you know what, Jessica, God bless your heart. She will tell me what's up. I got a couple of girls at work, but otherwise, like you students, I can go all day with a big hunk of lipstick on my teeth, before COVID, or something, a gob of something. Very few of you will be kind enough to be like, hey, Miss P, you got a little something happening right here. So thank you for those that do it. And the rest of you, karma. Mm-hmm. Karma. All right. Love you guys. Hugs and kisses. See you soon.